Okay, I am provided with the axial CT of the brain, which are non-contrast images. It is a 30-year female, which is presented with the tinnitus, headache, and loss of balance. The first thing I appreciate there is an hyperdense extra-axial lesions, which are seen in the left frontal lobe, causing compression over the underlying brain parenchyma, and these are extending into the parafalcine region. There is areas of necrosis is also seen within the lesion, no calcification seen. There is subtle surrounding bony hyperostosis is also seen, but I would confirm on the bone window. Another lesion is appreciated in the left parasagittal region, which is also seems an extra axial, causing compression over the underlying brain parenchyma, and there is edema signals is also seen at the level of the centrum semiovale and the corona radiata in the left cerebral hemisphere. On the right side, there is midline shift is also seen. No ventricular dilatation is appreciated. And in the non-contrast images, I can't see any lesion at the CP angle, and the rest of the structures seems normal. So I am concerning for the multiple meningiomatosis, but I would confirm on the MRI with pre and post contrast images for the further confirmation of my diagnosis.
Okay. I'll show you MR. Here you are.
Okay, these are the axial T2 weighted images of the MRI of the same patient. Here I can appreciate there is redemonstration of multiple extraaxial lesions with associated edema, which is confirmed on the T2 weighted images, and there is midline shift. However, no ventricular dilatation is seen. I am concerned another lesion is seen in the intraventricular region on the right occipital lobe.
Okay.
And I will confirm on the post-contrast images.
Just 1 second, please. Don't
Yes.
use the
Okay.
mouse.
Okay.
Don't use the mouse. I'm giving you, here you are, post contrast. With you now.
Okay. Okay. These lesions shows marked post-contrast enhancement. These are attached to the dura, and there is an evidence of dural tail sign. One lesion in the left frontal lobe shows areas of necrosis, and another lesion is also confirmed seen in the left parietal lobe. Another lesion is also seen in the right intraventricular region, which is close to the choroid plexus but seems inseparable from it. So these are multiple meningiomas. I am concerned from the concerned for the neurofibromatosis type 2, uh, in which I would look at the CP angles. I would also see on the coronal T1 weighted images if available, but I couldn't
Here you
appreciate.
are. I have
Yes.
got. Just 1 second. Let me slightly change the position for you.
Okay.
Over to you.
On the coronal T2 weighted images, there is no definite enhancing lesion seen in the CP angles. So I'm on the right side, there is no definite enhancing lesions in the CP angles. So I'm again thinking in the line of neurofibromatosis type 2, or it can be solitary meningiomatosis case. But I would advise the MRI whole spine to see any ependymomas in the spine. Okay, and that post-contrast images, multiple intramedullary intraaxial lesions, enhancing lesions seen in the mid-cervical spine, which are concerning for the ependymomas. So these overall findings are consistent with the neurofibromatosis type 2. I would take the prior history, a record of the patient if available, and genetic counseling is suggested, and I would
Why
refer
did
this
you
patient.
say neurofibromatosis type 2? Why did you say that?
Sir, because I see ependymomas in the spine.
And
Intramedullary
what is the
lesions in the spine.
definition? What is the clinical criteria to call a patient NF2 patient?
Sir, basically three things, multiple meningiomas, schwannomas, and ependymomas.
And with that, what else?
Sir, clinical criteria can be the axillary freckling and many other things.
That is NF1. You are confusing with NF1.
Yes,
What
sir.
I'm trying to tell you is that if a patient has got multiple meningiomas and ependymomas, and what else did you say?
Bilateral vestibular schwannomas.
So in this case, were there any schwannomas?
Sir, I am concerned on the right side, right CP angle. Enhancing lesion is also appreciated.
Eh, but You
And
you
see,
you
coronal.
you if you are you did not point it out to me. Where is it?
Sir, sir, uh, this area is concerning.
This is not the CP angle. This is not
Yes,
the.
sir.
So my whole of my debate is what is the criteria and has the criteria been met in this case?
Sir, exactly three lesions are not met, but ependymomas and meningiomas are present.
Okay, thank you. Thank you.
Thank you, sir.
Now, this is a case of NF2. Uh, by the way, NF2, the definition of NF2 is if a patient has got bilateral acoustic schwannoma, criteria met, end of story. Or if a patient has got unilateral acoustic schwannoma with positive family history, then the criteria is met. Or and if with that, positive family history or unilateral acoustic schwannoma, with that, if the patient has got multiple meningiomas and ependymomas. So family history is something which you have to remember. Now, in
Okay.
this particular case, we could see these meningiomas which are high density, and this one can argue that it is causing a bit of hyperostosis also in here, because it is next to it. And then there are, even on this non-enhanced, you can develop your eyes on this, that there are small lesions on the right side. And if you see here, this is an interesting one. And this has come in the exam in another context. So this is a very good teaching point on this case. If you see this hemangioma and place yourself in the world of trauma, so this is what came in the exam. There was trauma and the patient, and in my clinical practice, I have seen the same thing happening where this was called as an epidural hematoma. The key thing is that look for any speck of calcium there. And this is actually another meningioma, and I'll show you when I show you the MR. So otherwise you can, in the context of trauma, one can call it a epidural hematoma. Now here, there was a lesion in the the ventricle, which happened to be actually intra ventricular meningioma. Now, I showed you a T2 weighted sequence, and on T2 weighted sequence, uh, what has happened? I think it has gone mad. Just 1 second. Yeah, now it is fine. Now, you can see these are multiple lesions, but we are not going to. Now, here, I think you should have called that there is a bit of hyperostosis when a meningioma is next to a bone which is thickened. So that's a Brownie point. There's a bit of midline shift. And of course, this one I'll show you with contrast. Now, post contrast. On post contrast, all of them enhance. Actually, there are multiple others also. And these are the ones, the hyperostosis is again there. And you remember that epidural shape? So this is that one.
Yes, sir.
And there were others on the right side. Here you are. And then this is the intraventricular meningioma. The key thing is actually you were doing very well. I thought that you will. This is a type of exam case which, in this case, what has happened is that they have not done a classical IAM study, but your eyes were looking for it. And you see, look here, look here. This is enhancement, and this is enhancement. This is the cochlea, the flower I was talking about. This is the IAM, and this is the IAM. So this is a small meningioma. Sorry, schwannoma. Please remember, per se, this is an exam case. It has come in the exam. They will show you a cyst sequence with as small a schwannoma as this. So develop your eyes on this. Now, when you said that I can see on right side, but your eyes were going somewhere else. Actually, if you see your anatomy, this is the IAM. And do you see this enhancement here?
Yes.
Right? And similarly, it is the problem is that the patient is not symmetrical. Here you are on the other side. So it's a beautiful case where you can pick up bilateral acoustic schwannoma. And you did beautifully well because your mind was working on it. And so on a sagittal, this is again an exam case, but because your mind was working, you could pick up an ependymoma. So actually, the definition was met in this case, right?
Yes.
Overall, you did well. Now, so this patient is what happened was that this is a 60-year-old, left upper thorax pain, heaviness, rule out left upper lung lesion, question mark, question mark. This was the clinical. So left upper
Okay.
thorax, yeah.
These are the post-contrast CT chest axial images. I can appreciate in lobulated enhancing lesion in the left apex.
Where is it, madam?
So this is
Yeah, no, don't worry. This is related to the joint, so don't worry about it.
okay.
Yeah, there is a bit of fluid and some in the sternoclavicular joint. So I'm not interested there.
Okay. So great vessels are normally enhanced with the contrast. No definite mediastinal lymph nodes. Ascending, descending aortas are normal.
Yeah, because of time factor, just concentrate on the
Yes.
upper chest. Just concentrate on upper chest. Clinically, also, we are interested in upper chest.
Okay. Sir, I can appreciate lobulated lesion. There is an asymmetry between the soft tissue and lobulated lesion seen in the left supraclavicular region, which shows
Right.
bit of which shows heterogeneous enhancement, but I will see on the plane window to confirm it.
Mm-hmm.
So it can be
Just one second.
yes.
I'll give you a coronal also, just to
On the coronal phase, it can confirm
try
on
to pick.
the okay. Yes, this is the lesion,
Mm-hmm.
which is oval shaped and slight perilesional fat standing is seen, and it is abutting the rib.
Mm-hmm.
I will check the bone window to see any associated rib erosion is present or not.
I'm giving you the bone window.
There is no definite rib erosion or scalloping. There is subtle scalloping of the rib is seen.
Okay, subtle scalloping. Okay.
Yes.
Mm-hmm.
So it seems an extrapulmonary lesion.
Mm-hmm.
It can be the schwannoma,
Mm-hmm.
or other possibility is the necrotic lymph node. If any other primary is present in the head and neck or some other region.
So if it is a shunt,
And
that is arising from where?
sir, it can be arising from the intercostal nerves. That is why it is causing the scalloping of the rib.
What is the plexus which is in this region?
Sir, brachial plexus, which, yes,
That is
brachial
rising
plexus.
from the brachial plexus.
No, it is I think it's arising from the intercostal nerve.
And why do you say no?
Sir, it can be, but I think its brachial plexus is slightly above from the ribs, and mainly the nerves goes into the region of the axilla.
So
And
where is the brachial plexus? Which level do you see the brachial plexus? Which is the best investigation for checking the brachial plexus?
MR.
MR? Okay,
Yes, sir.
let me show you an MR. I'm showing you a T1 weighted sequence. Over to you.
O- Okay, sir.
I'll show you more. Yeah.
Okay, these are the T1 weighted images of the MR brachial plexus.
Mm-hmm.
I will scroll through the images and up to the area of the interest.
Correction, this is a T2. Sorry, this is a T2 I've
Okay,
given.
okay. These are this is the ligand is heterogeneous, peripherally hyper intense, and centrally the component is hypo intense. Okay, there is no associated any soft tissue infiltration. So
Mm-hmm.
I would like to see the post contrast images.
Mm-hmm.
I think it's giving a target type appearance on the T2 weighted images.
Yeah, this is the post contrast.
Yes, it shows heterogeneous post contrast enhancement.
How many
So
lesions are there? How many
yes,
lesions?
sir.
How many lesions are there?
Okay.
Let me give you another scan. Here you are.
So there are many other lesions are also, and this is along the brachial nerves plexus. So these are multiple
Why do you say
neurofibromas.
brachial plexus? Now convince me that this is the brachial plexus. What are the anatomic landmarks here for brachial plexus? What are the
Sir,
parts of brachial plexus? Tell me the parts of brachial plexus.
sir, there are trunk first trunks, then first are roots, then trunks, then
Show me the
further
root.
divisions.
On this sequence, show me the root of the brachial plexus.
Sir, sorry, I didn't actually report the brachial plexus MRI in routine.
Okay. So what is your conclusion? I love your
Sir,
answer. Well done.
sir,
So
neurofibromatosis type 1 can be multiple neurofibromas.
neurofibromas.
Sir, these are neurofibromas. Basically, schwannomas are neurofibromas, but there can be the possibility it is the patient if other criteria is met, but it can be solitary schwannomas.
Okay, let me take over. Okay, so this is a case of multiple schwannomas arising from the brachial plexus. So the point here is that brachial plexus is slightly, for me, slightly beyond 2B level, where nobody is expecting you to know the nitty-gritties of brachial, but a mass in that region is definitely 2B stuff. You have to pick up a mass there. And you have done very well. The only thing is that you did not know the anatomy of brachial plexus. Simple as that. Otherwise, you had picked it up. Now, I also warn you that in your day-to-day practice, how easy it is to miss this case. And by the way, it was missed. It was missed. And later on, the patient came back and with some other pain, etc. And then the MR showed it. Now, if you see here, that the asymmetry and now from today develop this as a key area for yourself. What I've seen is that people look for lymph nodes, thyroid, people look at the axilla, the eyes don't go into this area. So this was a brachial, there is a lesion. Now, even on this CT scan, actually you had clinched your diagnosis. You did very well, and this is elliptical shape. You can convince yourself that from there a nerve is going, distal to it. It is elliptical shape. You did very well when you picked up scalloping. So there was a bit of scalloping. And the key landmark for brachial plexus is the scalenus anterior and medius muscle. So tomorrow when you see an MR of the cervical spine or a CT scan, try to look for this anatomy. It is so easy. The muscles here are, now if you see here, this is the scalenus anterior, this is the medius, this is C7T1 level. Okay, now
Yes.
between the two are the roots of the brachial plexus. Just remember that is the axial landmark. So these are the roots. Now from there it will come into what we call the posterior triangle or of the neck. Here will be the, and the first part will be trunk, then will be the divisions, then will be the cords, and of course then in the axilla, the cords will be in the axilla, and then of course the branches. So here one can argue that even if you don't know too much of anatomy, now this is scalenus anterior, this is scalenus medius. Now here there is a tumor sitting here. And this tumor is just like your bigger tumor here, which you had picked up. And there is another tumor sitting here. One, two, three. And if you look carefully, then distally also there is another one, but that is very well seen on other sequences. So on this, this is a stir sequence on which you can actually, this is the small one. This might be arising from the branches. One, two, three, four. One, two, three, four. So Schwammt, Schwammt, it is a tongue twister for me, but multiple schwannoma, schwannomatosis, whatever you call it. Uh, uh, I find this word always a tongue twister for me. Multiple schwannomas. Don't confuse it that this will be in keeping with what we call NF1. You can raise the issue, but don't call it. It is a known and
Yes.
multiple schwannomas can occur. So today you have learned something new. But please
Thank you,
remember,
sir.
if which I showed you was a classical 2B, you have to pick up as a tumor. And when you see the elliptical and it is in continuity. Now, even here, if you stretch your imagination, you can see the nerve. One question, please remember this concept that these schwannomas, they are usually slightly eccentric. And the key question, which is in your clinical practice, you should have this idea. Will you do a biopsy? Don't ask for a biopsy because in biopsy, you can actually needle the nerve and damage the nerve. On the other hand, when they do surgery, it is very easy to remove these kinds of lesions because they are eccentric and they can remove from the nerve. So in surgery, they are much better. If you do a biopsy, you might cause nerve injury. So that can be a potential question for this. Thank you very much.
Thank you so much, sir. Thank you.
Okay, candidate 4, are you with us?
Yes, sir. Assalamu alaikum.
Okay, so candidate 4. Now, easy case. I've selected you very, bread and butter type of cases for you. Now, please remember that the format which I am going to use is in the next few sessions is, CT and MRs, and I want to do a bit of teaching just like I'm doing today. So tell me in the feedback if you find it useful. Because I'm describing it, I'm giving you a bit of theory. Unfortunately, what I have learned is that if I start displaying PowerPoints also, it becomes a bit too much. So I'm doing it just on the scans. And if you like it, I can continue. But my idea is to do, I've got a lot of cases, fresh cases where which will really be which will check you. So for the time being, I want to continue with this. Now, this is another very interesting case. What happened was that candidate 4, are you with us?
Yes, sir.
Now, this case was in the private sector, they did a cholecystectomy 5 days prior to this scan, and then came to NHS and came to A&E, and they said that the patient has developed right upper quadrant pain after cholecystectomy. They said that we are worried that there might be some infection etc. So classical right upper quadrant pain was there. Over to you. This is a
Sir, I can.
30-year-old. Oh, sorry, I'm not projecting. Huh? Sorry.
Yes, sir. Yes.
Maybe I have. Over to you.
Sir, I asked for the remote.
Yeah, the mouse is with you.
Yes, sir. I've been presented with the CT scan axial section post-contrast images, who presented with in the A&E post-cholecystectomy in the right upper quadrant plane. I would like to scroll through the images first and then give my findings. I'm
Just
scrolling first with
concentrate
the
in the, in the
liver.
on the right side. Just concentrate there. I don't want you
Yes,
to.
sir. Yes, sir. Sir, I can see the surgical clips around the area of gallbladder. Apart from that, what I can see is the multiple well-defined hypodense lesions, which are scattered in the predominantly in the left lobe of the liver, and they do not seem to be having any enhancing walls. Apart from that, I can see a loculus of air in the that appears to be uh, that I would like to further confirm it in the lung window to see whether the air, which
This,
is
this was in the
just,
colon. This was in the colon. This is colon, so don't worry. The colon has actually gone into the gallbladder fossa, so it is all colon.
okay, sir. So there is most probably no free air, I
No
guess,
free air.
because
No free air.
it's, so the more concerning findings are actually these multiple well-defined
These
hypodense
are
areas, which
multiple
are
small
cysts.
cysts, and these were known. Don't worry about it.
Yes, sir. Um, Sir, apart from that, I can see a small loculus of air that is likely adjacent to the first part of the duodenum, the
No, that
first
is
at the
also
junction.
within the lumen. That is in the D1,
Yes, sir.
so don't worry about that.
Yes, sir. I was more concerned about any fistulous communication that might be there. So,
Mm-hmm.
sir, the stomach wall appears there. I cannot. I'm not able to appreciate any breach in the stomach wall or in the duodenum. I'm not able to appreciate
Okay.
uh,
Mm-hmm.
any free air or any loculated collection. Uh, Also, there is definitely free fluid in the pelvis, and there is a mesenteric fat spreading and mesenteric congestion.
So right-sided pain, hepatic region. Look in and around the liver, other than the areas which you have already looked at.
Sir, sir, I am concerned for any leak from the from the duct, which is, however, I'm not able to
A hint,
appreciate any.
hint.
Yes, sir.
Uh, segment 6, below segment 6. Anything you see that?
So I can see in the kidney. Sir, in the kidney, I can see that there are multiple cysts, but apart from that, uh, there is a wedge-shaped area that is centered upon the posterior aspect of the kidney,
Okay,
communicating.
I will take over. Thank you.
Yes, sir.
So the point is that this was a very, very interesting case. And if you Google it, there are case studies on this. Basically, what is happening is that this patient actually presented with symptoms of right upper quadrant pain because of liver capsule being irritated. Actually, the problem was that, do you see this thing here? This thing. This thing, what do you think is this thing?
So
Candidate.
I cannot see your marker. I cannot see your marker, sir.
Actually, I can see the mark. In any case, this is the right paracolic gutter. What is this?
Yes, sir.
What do you think is this?
Sir, this area?
Yeah. What is this?
Sir, this appears to be some fistulous communication.
Yeah. So this is a
Yes, sir.
ectopic type of appendix.
Oh,
Yeah.
appendix.
So this now on this coronal, you can see this.
Yes, sir. It is going up. Yes,
It is going up.
subhepatic.
It is touching the capsule, and this you Google it and you will see case reports on this. Because what happens is that when acute appendicitis happens, the patient might present with pain up there. So this is what was happening. Okay, so this was an observation case. Now, last two cases of the day. And what I have done is that I have selected sort of similar case for you. Madam, can you see the
Yes, sir.
image?
Yes, sir.
So
I've been present.
this is a 30-year-old, and she has presented with headache, cognitive deficit, etc. A CT was done, followed by this MR. Headache, cognitive deficit, deficient,
Yes, sir.
deficit.
Sir, I have been presented with the MRI. Sir, these are scrollable images.
Yes, yes, yes. You can ask for
I
mouse.
will.
Yeah, with you.
Sir, yes, sir. Sir, I've been presented with the MR flare images, axial sections, in which I can see that there is hyperdense signal that is centered upon the basal ganglia, thalami, bilateral,
Hyper
symmetrical.
intense, hyper
Yes,
intense. We use
a
the word
hyper
hyper.
intense signal.
Yeah, yeah.
Hyper intense signal centered upon the bilateral thalami in the basal ganglia as well as in the periventricular region. And I would like to scroll further. No other similar hyper intense signal seen in the cerebellum or in the brainstem or in the cerebellar gray matter. So considering these, I would like to further see it in the diffusion restriction and the post contrast images, if
Just
available.
go down.
Uh,
Just
yes, sir.
don't scroll. This is the DWIC.
Yes. Yes. I've been presented with the DWI images in which the before mentioned areas does not show any significant high signal on the DWI images. However, subtle foci do show high signal, but predominantly the areas involved do not show any significant high signal apart from the patchy few signal areas. Sir, can I see this area in the gradient images?
Gradient.
Sir, in the
SWI.
gradient, yes, sir. In the gradient images,
This is a SWI, right? There is a bit of difference between the two.
yes,
But
sir.
physics
Yes, sir.
is just 1 second. Let me give you a map which is better for you. Here you are.
Yes, sir. The gradient also does not show any blooming artifact in the concerned areas. Considering the cognitive decline, my first differential in this case would be an encephalitis, which could be autoimmune, as it is involving the basal ganglia and the thalami. Apart from that, I would like to consider as it is involving, although I'm not able to see any hemorrhagic foci, so my dengue encephalitis would be ruled out because it is more concerned in that is of diagnosis when there is more of a hemorrhage and blooming in the basal ganglias and the thalami. Apart from that, I would like to take the history of the patient, and this is also an emergency finding. I would like to advise for the refer this case to this neurosurgery and advise for the CSF analysis. Uh,
Okay, madam,
Although I
do you see
yes,
that you have not commented on the temporal horns? What's happening there?
yes, sir, there in the temporal horns there is area of similar high signal, intermediate
No,
to
no,
high
no.
signal.
Are these horns dilated or not?
Yes, sir, these are. Yes, sir, these are dilated.
Why are
These are
they?
prominent. Sir,
There is hydrocephalus, right?
yes, sir,
What?
there is mild hydrocephalus.
Mm-hmm.
Um,
You were just giving me the diagnosis. So dengue, what else? Viral? Anything else?
Sir, autoimmune and herpes, less likely because the temporal lobes are not uh, predominantly involved.
Okay, thank you very much. Thank you. Let me tackle it. So this case is chat. Question for chat. Anybody got it? Give me your answers in the chat. 291. Oh, sorry, chat is. Anybody?
Japanese.
My chat is not working actually. What have they given the answer?
Sir, lentiform folk sign, uremic encephalopathy, CJD,
Okay,
Japanese
okay.
encephalitis, NMO.
Excellent. So this is a very, very interesting thing that the eye see what the mind knows type of a thing. I have
Japanese.
shown you a case which I had shown you a CT, you would have picked it up. This is simple as that. This is dural venous sinus thrombosis. And so what is happening is that on this flare sequence, please remember the anatomy. The anatomy is that internal cerebral veins, they drain into the vein of Galen, which goes into the straight sinus. And of course, then the straight sinus, the superior sagittal sinus, so the main thing is in this part, when there is if you go to the pathophysiology, what happens is that dural venous sinus thrombosis, that there is basically venous congestion, venous edema, and that is why there is at this level there is compression and hydrocephalus. Now, you see, this is the foramen of Monroe, etc. It is even the aqueduct might be compressed. Now, bilateral symmetrical basal ganglia are involved, and the thalami are involved. Now, so in this particular, whenever there is bilateral thalami involvement, the differential diagnosis should be very clear. Your differential vis-a-vis infections was good, but you did not cover dural venous sinus thrombosis. And also remember artery of Perkinon infarction where both thalami will go. You did
Sir,
well
even
where,
without restriction, without restricted diffusion.
again.
Sir, no restricted diffusion.
Of course, of course. So the point is that in venous infarctions, there can be with restriction complete recovery. By the way, even with restriction. So restriction is not at all a criteria for venous. It's not a very good criteria, should I say? Now, whenever there is hemorrhage, there will also, because of that, it can be restricted diffusion. Subacute hemorrhage can cause restricted diffusion. So coming back, now with that, so bilateral symmetrical findings. Now on this flare, if you go up, and this is what exams are about, look here what is happening. This is the superior sagittal sinus, and then look at this. Nothing in the sulcus should be high signal on a flare sequence. If it is high signal, means it is either the blood or in this case, it's a clotted cortical vein. So if I just give you this flare, I want you to pick this up. And now other than that, as you have pointed out on the DWI sequence, there was nothing significant, just a few specks of restricted diffusion. Now, then you never asked for it, and I did not show you. But having said that, you can develop your eyes to pick up these kinds of findings on regular sequence. In your day-to-day practice, it is my protocol that if you have got a sagittal, a coronal, particularly a coronal T2, develop your eyes to look at the signal within the superior sagittal sinus. This is the superior sagittal sinus. Just keep looking at the superior sagittal sinus. And here the signal goes. It should be dark. it should be signal void. And these are the cortical vein which are thrombosed. And that is why this cortical vein was high signal on the flare. And as I'm going back, you can actually pick it up 2 plus 2. I'm not saying that you should pick up on a T2, but you should develop your eyes. If you're, and this is the importance of I see what the mind knows, and developing your eyes to pick up subtle finding on available sequences to help you. Always a T1 can help you because on T1 there can be high signal. Now here, you remember what I showed you here? There is high signal here, and there is no high signal. It all depends on the age of the infarct. When it is hyperacute, you might not. But this high signal is enough to call it. Now, what will you do? So, what you will do is that you will ask for a venogram. And if you had picked it up, I would have shown you a venogram. And the CT venogram is investigation of choice, much better than a uh, MR venogram. Having said that, of course, MR venogram is not bad. Now you can see this filling defect here. You can see this filling defect, superior sagittal sinus, it's all gone. And as I go posteriorly, you can see this filling defect. You can see this on transverse sinus. And by the way, a sagittal is always a very good sequence. On sagittal, sorry, I'm showing you without contrast. I want to show you with contrast. Now, here you are. Even the straight sinus filling defect is visible. Go to right and left, and now I'm going to one side, and you can see this filling defect in the transverse sinus. Go to the other side, and this one is hypoplastic sinus. It's a normal variant, and the main infarct is so filling defect is on the other side. In this particular case, I did not show you the CT, but the CT is an exam case. I think in my teaching I have shown you similar cases, so I just wanted to show you MR, and I knew that you will find it difficult. This is the original CT, and this is a classical exam case. This is just like hyperdense basal artery sign or hyperdense MCA sign, where venous infarcts can be picked up when they have got high density on a non-enhanced CT. Now look at the anatomy. This is the internal cerebral vein. If I had asked this, I would have asked you to pick this up, internal cerebral vein, and then the straight sinus, all hyperdense. If I go back, you can see all of this density. It is all thrombosed sinus. Now, if I go to the superior sagittal sinus, here you are, and here, and you can still convince yourself that this is high density. So this was a case of dural venous sinus thrombosis. Okay, last case of the day. Okay, madam. 65-year-old. The patient presented with personality change, and they said rule out of frontal lesion. So you know that the clinical concept is that if the patient has got frontal lesions, etc., it can cause personality change. So this is what they had asked for. 65-year personality change, frontal lesion, question mark, and this was the CT scan.
So I've been presented with the CT scan, axial scan, section images, in which I would like to first scroll through the whole images and then give my findings. While I was scrolling from top to bottom, the first abnormality that I noted was the presence of air adjacent to the forks
Uh, so,
here.
so can it be anything else?
Sir, it can be fat,
It
like
was fat, and that is a pitfall. You don't tackle it like this in the exam. You ask for HU, and Fox fat is a very known normal variant, right? It was fat. Hmm.
so, sir, apart from that, I would like to, I'm not able to appreciate any gross loss of gray-white differentiation. The basal ganglia appear. Sir, on the right side, there is yeah, there is generalized hypodensity noted centered upon the basal ganglia and the thalami.
Basal ganglia?
Uh, sir, in the thalamus.
Thalamus. Okay.
In
Okay.
in the thalamus, yes, sir. Partly involving the left side as well, but more on the right side.
Okay.
And apart from that,
What will you do?
sir, I would recommend for an MR for this
Okay.
patient.
Okay. Yes, madam.
So I've been presented with the MR of the same patient, in which I can
You can
see
ask
that there is an
for the mouse, please,
yes, sir.
with you. Okay.
Yes, sir. I've been presented with the MR images of the same patient, in which I can see hyperintense signal centered upon the bilateral thalami, and also partly involving the bilateral temporal lobes, as well as part of brain midbrain of the brainstem as well. So, considering this high signal, I would like to further see it on the diffusion weighted images, as well as in the post contrast images.
Okay. So,
To
just 1 second, please.
yes,
I
sir.
think I have,
It is restricting.
yeah, this is the DWI, right?
Yes, sir.
And
It is showing facilitated diffusion, not much restricting on ADC.
hmm,
So, sir, I would like to know the
huh?
history of any initial
So,
viral infection. Yes, sir.
so
On the
I'm seeing
post-contrast
the
images.
post contrast. This is the post
Yes, sir.
contrast.
This is subtle patchy enhancement, no significant enhancement. Sir, considering the involvement of the bilateral temporal lobes as well as the thalami, again, sir, I would like to first see the coronal images in the post-contrast, just to give a look at the sinuses.
Coronal post contrast. I am doing it for you. There was no
Yes, sir.
enhancement.
Yes, sir. There was no enhancement and no gross filling defect in the sinuses. So, sir, again, midline hyperintense signal, bilateral or symmetrical almost, uh, involving the temporal lobes and the deep thalami. So it can be the first differential could be encephalitis, could be herpes, because it is involving the temporal. But again, of course, I would like the autoimmune encephalitis and Japanese will be in the
Patient has got
differential.
no signs of any inflammation, infection type of findings, sorry, clinically. But you continue with your differential. What else?
Sir, apart from that, it is less likely to be a deep cerebral sinus thrombosis. As I can see, no filling, gross filling defect in the visualized sinuses, and the deep cerebral veins appear to be patent. I would like to see
So you
the
have seen
artery of
whatever you wanted to see, and there is nothing else for me to show you. You just give me the final diagnosis.
sir, bilateral thalamus involvement can be in the artery of percuron thrombosis as well,
So
because it is restricting us.
acute infarction. No, so the ADC was not there.
Yes, sir. Um, sir, other midline central uh, could be sir.
Anything else?
I'm not sure.
Chat. Anything else? Final diagnosis. Madam, what is written in chat?
Yes.
I cannot see my
So,
chat.
sir, it's carbon monoxide poisoning, neurocytoma, central
CJT.
CJG.
Okay.
Yes, sir. And
Uh,
sir,
okay.
cadasal, and
CJT.
glioma, Japanese
Who said glioma? That
CDG,
is the correct answer.
glioma, sir. Dr. Fahad Abdi.
So a few hands for whoever said that. Okay, well done. Now,
Pandemic gliomas.
Yeah, this was glioma. Now, if you open a book of differential diagnosis, and this is why I say to people that you must remember, refer to a book and you must try to remember at least some differential, some bookish differential of a particular condition, because your mind will keep working like this. But I'll tell you more than that. For me, the top four differential diagnosis for bilateral thalamus. So if you see, just Google it or Radiopedia it or whatever. But I read Stat DX, what is the called? I think specialist differential for head and neck and brains. So they have divided it into most common, less common, and least common. And of course, the differential diagnosis is quite big, as you people have mentioned in the chat. But the top four, and try to remember those top four, they will save the day for you. Top four include a bilateral dural venous sinus thrombosis, which I had shown you, artery of Perkinon, which is a variant because both thalami will go because of that acute infarction. And then, of course, in children, always remember Adam, in children particularly and young adults particularly, because please remember, Adam is a white matter disease which also involves deep gray matter. Remember that. And deep gray matter, thalamus is a deep gray matter. And then the fourth one is gliomatosis. End of story. These are the top four. What is gliomatosis? The anatomy is that the thalami are interconnected, the massa intermedia or whatever you want to call it, and the fissure. And gliomatosis, by definition, is, two or more than two, some people say three lobes, diffuse infiltrative tumor, which goes from right and left. And the key thing to remember in gliomatosis, it is a grade 2 astrocytoma. It is not a grade 3 and grade 4. But later on, in final stages, within the lesion, uh, there can be degeneration into grade 3 or grade 4. A grade 2 lesion will not enhance. Remember that. So it is a tumor which might not enhance. Of course, when it enhances, you call it. And the another thing with gliomatosis is that they say that the radiological features which will be much more than the clinical features. And there will be preservation of architecture. Remember that term, preservation of architecture. It will be a huge abnormality. And in gliomatosis, sometimes five lobes might be involved. And if you see grossly, except for the signal, you won't find, some abnormality. So this was a case of gliomatosis. And so in this particular case, this is a CT scan on which both thalami you picked very well. And but you'll agree that it was a subtle finding, easy to miss. And right and left something is, and then your thought process was good, and that is why I have shown you these two bilateral thalami cases together, so that at least you people remember today bilateral thalami and the top four I have told you. Infections and all those things which you have put in the chat, you are absolutely right. But the top four are venous thrombosis, arterial thrombosis, Edem in children and young adults, and glioma. These are the top four. And I'll keep herpes as number five, or other infections as number five. Now with that, if you see the MR, so let's go back to the flare. And flare looks horrendous, isn't it? And so it is such bulky, the signal intensity bilateral, and this is the connection between the two thalami. And actually, I'm showing you a not a flare. Correction. I'm showing you a what we call a diffusion. Actually, just one second. Let me show you the flare. Sorry for that. This is the flare. Now, look at it very carefully because it shows you everything beautifully. Look at the thalamus right and left and the connection, and this thing goes right and left, and this is what architecture, I was talking about the architecture is from here it goes into the internal capsule posterior limb, but then what it is doing from here, the corticospinal, it is going into the middle brain. And then do you see that the occipital lobes are involved? And do you see that the medial temporal lobes are involved? And you will agree that the architecture is absolutely preserved. So this is what it does. If you start counting the lobes, temporal lobe and occipital lobe, and then the midbrain, and then thalami is, it is so many lobes which are involved. So this is gliomatosis. And of course, a herpes case will also present similarly. Remember that. Herpes can also be, even last week I saw a herpes like this, which can be, temporal lobes and all those things. So that will be in the differential diagnosis. Now, please remember the concept of that enhancement or lack of enhancement will not change your management. And as I always say, that know your pathology, make your radiology. And the pathology is that this is a grade 2 tumor and it will not enhance. When within the lesion, there will be degeneration to grade 3 or grade 4, that will enhance. You will see necrosis, you will see even hemorrhage. I have seen that. So this is gliomatosis. Okay, well done, candidate 4. So thank you very much. So if you see today, I did a new format in which I have done a lot of teaching just on the images. If you like it, give me a feedback. And that is why I had kept 2.5 hours for this. I've actually gone beyond that. But I think quality teaching is something which yeah, I appreciate that some of you might be logged in right now from far away. So uh, so the point is that give me comments if you like it. Uh, I want to continue with this format for the next few sessions at least. Next few sessions at least. Okay, let me display the feedback form, and we have got a co-host. If you can please put it in the chat. So see you next Thursday. It will again be my own session next Thursday, similar format. Thank you very much. I have not seen the chat. If there is any, I have infarcts will not enhance. So infarcts usually do not enhance. The concept is that when the blood-brain barrier is broken, they will enhance. And that happens usually 5 days down the road. So that is the concept of, uh, and this is why they say never give contrast in a case of uh, infarction. So the concept is blood-brain barrier when it is. I can see a lot of comments in the chat. I think you like this format. So in any case, I will continue with this. Basic is a lot of teaching on the images. Okay then, see you next week. Good night now.